India, ma'am.
Yes, so good afternoon. So we have had an interesting series of case presentations by Dr. Rakesh and Dr. Mahija. So I'm following through with the same. And I'm really grateful for the organizers for providing us with such a platform for showing you some of the cases which have helped us in learning and which hopefully will help you all also in learning many of the things. So I'll go directly onto my cases. Some of these cases are simple. Some of them you'll be able to diagnose it from a first look. Some of them require a little more thinking. But you will see that many of the clinical features match with other lesions also. So that's why we need a wider thinking or wider knowledge. First case is a 4-year-old boy presented with a complaint of swelling in the lower lip, which had been present for 1 year. It was slow growing, about 1.5 by 2 centimeter, and it was bluish in color. Now, there is no clinical picture, but this is a gross specimen which we received. The clinician or the surgeon had removed the whole lesion in one go, and we got the specimen. Now, as you can see, as I mentioned, the clinical features, the lesion is present in the lower lip. So the differential diagnosis, what we can think of when we think of lesions in the lower lip, first and foremost, what comes to us would be, and another thing is bluish in color. What you would think of as a mucocele, and mucocele was the differential diagnosis which the clinician gave to us. Now, other things what we also can think of when we think of lesions or swellings in the lower lip. Yes, salivary gland lesions. It can be other benign salivary gland tumors. So it had a history of being there for 1 year. So definitely slow growing. Surface appears to be smooth. Blue color. Again, salivary gland. Then again, blue color or color. Another thing what you can think of is vascular lesions. Hemangiomas are common in children. So is it a hemangioma? It can appear like that also. So we section this, and what you can see here is, you can see some kind of a mucoid, a jelly-like material inside. Now, of course, mucocele or what the surgeon, one of the differential diagnosis, clinical. Of course, mucoid material can look like this, but another thing what you can think of when you see something like this, a jelly-like mass inside you can see the well-defined area outside in this gross specimen. So you can think of parasitic lesions also. So at the back of your mind, parasitic lesions can also be considered. But first and foremost, always consider the more common one, and here the more common one is, of course, mucocele. Now coming to the histology, you can see here, we can see the superficial epithelium, a stratified squamous epithelium is seen, and we are seeing a cavity beneath. Adjacent, what are the areas? You can see a kind of normal looking connective tissue here, apparently normal looking connective tissue. There's some salivary gland tissue here adjacent to it. So we'll go deeper into the part. Now here, this appears to be a cystic cavity. And of course, when we see cystic cavity, first thing what we should look for is the presence or absence of a cystic epithelial lining. So that is not visible in this particular picture. So another picture from another area. Now here also you can see the superficial stratified squamous epithelium, which seems to be almost even. There's a band of almost normal connective tissue beneath that, and beneath that is this cystic cavity. And here you can note that there is no epithelial lining. There seems to be some kind of fibrous connective tissue, compressed fibrous connective tissue, and beneath that the cystic cavity is seen. And here we were fortunate enough that the luminal contents were still retained. And what is inside the lumen is basically mostly eosinophilic mass. More higher power, again, you can very clearly see now. that there is no epithelial lining at all. You're seeing mucin here, and admixed there with that, you're seeing a lot of inflammatory cells, basically more of lymphocytes. And there were a lot of hemorrhage. Maybe that is why it appeared, the cross section appeared, in some areas it appeared black or very much brownish. So a lot of RPCs were there admixed with the mucin content, which gave us that particular color, and also that was responsible for this darker staining in these sections. So again, a deeper power or a higher power for you to see the content and appreciate the absence of epithelial lining. So I think most of you would have diagnosed by now. Again, one more feature was there, that is the adjacent salivary gland. So how is the nature of the salivary gland? So you have to look into that, whether there is any salivary gland pathology there. So basically, you could see more of mucus cells, some demillunes were there, but basically the salivary gland appeared to be normal. One ductus here, which appears to be slightly dilated. So inflammatory infiltrate appeared to be moderate, not very severe. So we're putting together all these features. What you have to think of is mucocele or mucus. Of course, what we call it is as mucocele is mucus extravasation phenomenon. As you all know, mucoceles can be either extravasation or retention. So the absence of lining is usually seen in an extravasation phenomenon. So this is a case of mucus extravasation phenomenon. So this is a pseudocyst, and it has a high predilection for the lower lip, basically mostly due to trauma. And mostly patients give a history of having recurrent or intermittent swellings which appear and go. And there might be history of trauma also. And the bluish color, all these, especially superficial lesions, are bluish in color. Deep-seated ones may not appear that much bluish. So what this case should tell you is always go for the more common. It is the most likely diagnosis. So a very simple case of mucoceles, but you should not miss out. So seeing the salivary gland, the adjacent salivary gland with the presence of that huge cavity inside. Okay, so with that, I'll go for the next case. Now, this is a case of a palatal swelling in a 71-year-old male patient, which is present for 2 years, and there were no associated symptoms. So from these features, what you can make out is it's a long-standing lesion, and it is present in the palate. You've already seen one case earlier, which was in palate, which turned out to be a connective tissue neoplasm. So again, think of what Dr. Rakesh was saying earlier, all the differential diagnosis when you think of palatal swellings, again, you have to come in here. Now, this area, if you look at the site, it is more posteriorly at the junction of hard and soft palate, more towards one side. So this area, when you think of, when you see lesions or when you see swelling in the posterior palate, one lesion or one set of lesions come foremost into your mind because of the normal histology, and that is salivary gland lesion. So salivary gland lesions are very probable in this area. Another tissue, what is here is the connective tissue. Adipocytes are common here. So you can get lipoma here, that is other connective. All other connective tissue neoplasms are also possible. Then again, the surface, I don't know if it's clear, but the surface shows some amount of surface capillaries were there. So you can think of a hemangioma also, but there are other features, clinical features of hemangioma by which you can differentiate them. But you have to keep in mind that it could be a connective tissue pathology. Now, is it benign or would it be a malignant? It's a long-standing case, almost 2 years. So more likely to be a benign, and also patient doesn't have any other features or any other symptom. There is no surface ulceration other than the obvious higher amount of capillarity. So obviously, or more likely to be a benign lesion rather than a malignant lesion. But of course, there are some of the salivary gland low-grade tumors which may appear, they may appear stagnant, or they may appear there for a longer period of time and may not show much of malignant features. So it could be, so at the lower end of your differential, so you could think of malignant, benign salivary gland pathologies, benign connective tissue tumors, and of course, the malignancies. And of course, you have to think of other odontogenic tumors also. Then, of course, X-ray, you need a radiograph. Here, a CT image showed, I hope it's visible to here. I'm showing you there's a soft tissue density here in the palate. In all the three pictures, you can see that. And there is no involvement of the underlying bone. So basically, it is a lesion which seems to be rather well defined and basically composed of soft tissue and not causing any erosion of the palatal bone. This again gives you a higher probability for it being a benign lesion rather than a malignancy arising from the tissue, whether they're arising from the epithelium or the connective tissue present in the palate. So let's go into the histopath. Now, the histopath is, I think, a spot diagnosis. Maybe some, if you can diagnose it, you are free to put it into the chat box. What you're seeing is basically proliferation of, you're seeing these presence of these tumor cells in long cords, and in some of the areas, these cords are enclosing luminal spaces. The adjacent connective tissue appears to be loosely collagenous and a higher power. Okay, this is again another area. It appears to be cords of columnar cells and appears to be single layered. Now, this is another picture here. Again, what you can make out is these columnar cells, single layer of columnar cells arranged into larger ductal spaces, and here the folding and adjacent layers appear to be closer together, giving a characteristic bilayer picture or a party wall appearance, which is very much a conclusive feature of canalicular adenoma. So, of course, one thing here, you should not get confused with the plexiform ameloblastoma, where again you can have this plexiform ameloblastoma where you have cords and network of the ameloblast-like cells with stellate reticulum. Here, there's no stellate reticulum. Here, the tumor cells are all these the columnar cells. So basically, in canalicular adenoma. Excellent presentation. Excellent. So I'm sorry. So you have the tall columnar cells. You have the cuboidal to columnar cells here, giving a party wall appearance, which is the diagnostic feature of canalicular adenoma. Now, canalicular adenoma is very much, it's a tumor of the minor salivary glands. It's more common in the oral cavity, in the minor glands rather than in the major glands. And it has a higher predilection for the upper lip. If you remember your Schaefer's, when we talk of salivary gland tumors which present in the upper lip, first and foremost, you think of canalicular adenoma. Now, canalicular adenoma usually has this particular picture where you have long cords of cuboidal to columnar cells which enclose. Sometimes they are dilated to produce these kind of luminal spaces, and sometimes this is a picture not from our case, but from an article by showing beading of these cells. Now, this again, the D picture, you're seeing something called it's known as a squamous ball or morule, which is specific for canalicular adenoma. And also there are cases in which you may get these kind of calcifications in canalicular adenoma. And these calcifications, they look like Samobor bodies, but they are not actually Samobor bodies, and they are known as microliths. And they have also been reported in some of these canalicular adenoma. And again, canalicular adenoma can be multifocal also, and sometimes they are usually nodular. They can present with the capsule. Sometimes they are uncapsulated also. In our case, there was no capsule and the lesion, but the margins were all clear and the tumor had come in a hole. So here the basic take-home message for this particular case would be: you think of the site. Where is the lesion seen? Think of the cases which can probably arise in that region. Your diagnosis will be very close to that particular region or particular to that location. So, and for a canalicular adenoma, it's a one-spot diagnosis, mostly diagnosed on a LOPA view or a scanner view, where you can see the typical canalicular pattern, which is very much characteristic for a canalicular adenoma. Coming to the third case, now this was a rather interesting case in the sense that the patient did not have any symptom. A 24-year-old female patient reported to our clinic for a orthodontic correction. And in the course of examination, the surgeon or the clinician felt a swelling in the retromolar area. There is a palpable swelling. There was no obvious inspectory swelling as such, but on palpation, a swelling of about 1 by 2.2 centimeter was seen in the right retromolar area. I don't have any clinical photographs because basically, since nothing was visible in the oral cavity as such on a visual examination, there is no photograph taken. But there was a palpable swelling in the right retromolar area. Initially, a biopsy was done, and the biopsy did not show any feature in the sense that there was no lesion at all, only a superficial epithelium and underlying normal connective tissue was seen. So naturally, we spoke back to the surgeon. They said, no, there is a swelling, there is something there because we're able to feel something. So I said, okay, maybe the biopsy was superficial. So you maybe go for a more deeper biopsy. Then they did a CT scan, and a CT scan revealed, as you can see in both the section, and this arrow is showing you, there is a soft tissue density here. And here it is seen between the pterygoid plates and the condyle of the mandible. You can see a soft tissue compared with the opposite side. Here, this is the normal picture. And on the right side, you can see the soft tissue density here. On the right side here also, you can see in the second picture also, it's seen lateral to the maxilla between the mandible and the maxilla. That's the condyle of the mandible and the lateral surface of the mandible. It's somewhere in the in the retromolar area, means see the upper extension of retromolar area would be the pterygoid fossa. So all those areas is something, there's got a lot of potential spaces there. So you have a lesion here, which is rather significant. It is not small, it is little big. And so since the initial biopsy was not confirmatory, or there is no lesion as such in the initial biopsy, which is done under LA, the surgeons decided to excise the lesion under GA. So this is a picture, which is the intraoperative picture, where we can see that that is the mass which mass which has been taken out by the surgeons. And this was the excised tissue, which is given to us with the margins which were marked. Now this the histopath which we received. Now, of course, I didn't discuss the differential diagnosis. Now, retromolar area is area where you have, see, it is the superficial epithelium seem to be normal. So you have a connective tissue. Mostly we thought of connective tissue neoplasms. That is all the benign connective tissue neoplasms, because there is not much of clinical findings. And the lesion seems to be, it must have been slow growing. There's no symptom. There are a lot of masticatory muscles there, right? The origin of masticatory muscles, the insertion of masticatory muscles is in that area, but patient did not have any symptoms related to that. No pain. So obviously what the clinician did think of were all benign connective tissue tumors. And that is what was in mind, maybe a schwannoma, a neural in origin, and of course any other connective tissue origin tumor could be there. Now, this is the histopath picture, which I briefly showed in between. What you're seeing is a connective tissue stroma, which seems to be infiltrated with islands of tumor cells. And these tumor cells are not very clear in this picture, but you can see the loosely collagenous connective tissue. The tumor cells are arranged into solid islands. Some areas, the tumor cells are showing kind of some cystic degeneration, or these cystic spaces. Here also one cystic space is here. And you're seeing some lighter stained areas, darker stained areas within these tumor islands. So going into the next part, Again, connective tissue stroma is enclosing these tumor islands. And if you look at the tumor cells properly, you're seeing different kinds of tumor cells here. You're seeing some cells with foamy cytoplasm. When you see foamy cytoplasm, the foremost what tissue comes to your mind? First and foremost is salivary gland tissue. Then another set of cells, what you see, they are more darker stained cytoplasm, the eosinophilic cytoplasm, more polyhedral. Then on the right-hand corner, you have some cells which appear to be slightly smaller with lesser amount of eosinophilic cytoplasm. So you're seeing, I'm sure most of you are able to make out what these cells are. These appear to be mucous cells, epidermoid cells, and the other cells with the lesser amount of eosinophilic cytoplasm are the intermediate cells. So another area is still a higher power, where in this picture, I think mostly you're seeing the mucous cells and some amount of epidermoid cells and some few intermediate cells. And also another thing what is obvious here is the higher amount of atypia, or there is some amount of pleomorphism within all these cells. There's a connective tissue septa here, or a fibrous band here separating adjacent tumor islands. And also another thing to be appreciated is the tumor islands are mostly solid. The cystic degeneration, when you think of all these three cells, of course, it's a mucoepidermoid carcinoma. But in mucoepidermoid carcinoma, we usually see mostly cases where there's a lot of cystic component. Here, the cystic component is comparatively less. But very obvious are the three kinds of cells here. Again, another area where the intermediate cells, I think this is one of the cases where I was actually able to really see and appreciate the intermediate cells. You know, the otherwise intermediate cells are very less than in amount in most of the tumor cells. We did a PAS stain where it was PAS positive. So obviously it is a mucoepidermoid carcinoma. Now mucoepidermoid carcinoma, as you know, you have three grades, depending upon which the treatment will also vary. And also, first and foremost, the prognosis for the patient varies, whether it is a low grade, which is usually the mucus-rich or mucous cell-rich tumors. Then you have an intermediate grade tumor, and the other end, which is the high grade, which has more amount of epidermoid cells. So giving a diagnosis of mucoepidermoid carcinoma is not enough. You have to grade it into either a low grade or a high grade or something which is intermediate in between. Now, as evident in the histology pictures which you've seen, there was the three types of cells are there. So it's of course definitely a mucoepidermoid carcinoma. There are mucous cells, there are epidermoid cells, and there is a lot of intermediate cells. Then again, the presence of cystic component is comparatively less, more amount of solid areas. And again, a lot of intermediate cells, as seen in that picture. There were sheets and islands of just intermediate cells alone also. So with that, we gave a diagnosis of a mucoepidermoid carcinoma of intermediate grade. Now, it's rather difficult. If you look at, there are different grading systems, as you know, Brand-Wain, AFIP, and of course, the modified Healy. These are the three systems upon which you can take for grading a mucoepidermoid carcinoma. There are different plus points and negative points for all the things for all the three grading systems. The first two, that is the Brand-Wain and AFIP, they use a point system. But the problem there is Brand-Wain tends to, when you put up the points, you find that you tend to upgrade the tumor into a high grade. And whereas the AFIP downgrades the tumor. But so there is a clarity or difficulty in grading an intermediate grade carcinoma when you see these two classification systems. So the easiest one, or which one I went along with, we went along with in grading this tumor, was the modified Healy, according to which because of the presence, the lesser amount of cystic spaces, the higher amount of intermediate cells, and also the presence of the other two cells and the atypia present, we gave it as a intermediate grade carcinoma, because we don't want the patient to giving a low grade carcinoma or the low grade diagnosis would end up with the patient not receiving proper treatment. Because as you saw the site, it is a retromolar area, which is an unusual location for a salivary gland tumor. So, and also that area is not an easily accessible area for the surgeon also. So whether the tumor, whether the excision alone is enough for the tumor is a very important question. And again, we don't want to give it as a high, because you know that it will involve resection, and this is a young patient who was not yet married. And so a lot of things come into play here. So we gave it as an intermediate grade carcinoma. And the problem here in this particular case was all the margins were positive for the tumor cells. So the surgeons went again in for another extensive resection, or rather a little more extensive surgery. And but unfortunately, the adjacent structure were bony structure, the pterygoid plates were removed, and the soft tissue attached to the pterygoid plates were also again positive for the tumor. So she also received some amount of radiation therapy, and right now she is undergoing the other replay, because a piece of the resection of some area of the maxilla was also done. She is involving on the rehabilitation process and implant placement, but she is sufficiently going forward in her life now. So the message from this particular tumor of this particular case, what I would give is, even in areas of which appear as innocuous or lesions which may at first glance, which may seem like benign, may turn to be malignant. And upon reading more about salivary gland tumors which arise in this retromolar area, what we found was that salivary gland tumors which are reported in this area are mostly malignant. So if you find a salivary gland lesion in the retromolar area, there are more chances for it to be malignant than for a benign. But of course, as I said, this was unusual. Initial biopsy was, there was no tumor tissue. Second biopsy, which the surgeon thought would have removed this lesion, did not remove the whole thing. And there were extensive surgeries to be done. But we could arrive at a confirmatory diagnosis with the HND slides itself. Coming to the last, so this is, again, this is just a picture showing you, as I said, low grade. Now, this is the left side picture is of a low grade mucoepidermoid carcinoma, where I said you see a lot of cystic spaces, and an odontogenic lesion, which you have to think of when you see a slide of a low grade mucoepidermoid carcinoma, especially if it is intrabony, is your glandular odontogenic cyst. Glandular odontogenic cyst can be mistaken for or low grade mucoepidermoid carcinoma can be mistaken for a GOC or vice versa. So there are certain distinct features for a glandular odontogenic cyst, which you have to look for, when you see a low grade. Make sure that it is not a low grade mucoepidermoid carcinoma, especially intrabony lesions. The soft tissue lesions, of course, you would not have much of difficulty, but in intrabony lesion, you can get mucoepidermoid carcinoma within the jaw bones. So in such cases, especially low grade, you have a differential diagnosis. What you have to think of is a glandular odontogenic cyst. So with that, we come to the last case. This is a little older patient, 54-year-old female patient, who had an initial complaint of ill-fitting dentures for a period of 3 months. She visited a local dentist, where the clinician felt that the mandible showed expansion, and OPG was taken, and an expansile lesion was seen in the mandible on the right side, and the incisional biopsy was done in a private clinic. The biopsy specimen went to a general pathologist who gave a diagnosis of ameloblastoma. She was referred here to Amrita for further treatment. And on examination here, what we could see was, if you see the comparison of both the sides, on the right side, there is a obvious facial swelling, which seems to extend from the corner of the angle of the mouth till posteriorly, it was extending almost till her earlobe, and superiorly it was extending till the zygomatic arch till the lower border of the mandible. Now the surface of the lesion appeared otherwise normal, but it was tender on palpation. Again, patient had the lower lip appeared to have a little lack of tonicity, and there was paresthesia on the right side of the lower lip. So, the intraoral examination, it was an edentulous maxilla and mandible. There was vestibular obliteration on the right side, and on palpation, there was expansion of the cortical plates, both the buccal and the lingual cortical plates. Now, even though the patient had a biopsy report of amyloblastoma. Now, if you look at the clinical features of the case which the patient presented with, there was an obvious swelling on the right side. There is a bony expansion. Of course, amyloblastoma does fit into all of these features. So it could be an amyloblastoma, but there are two additional features here which exactly doesn't fit into an amyloblastoma picture. That was the presence of or the symptom of paresthesia and lack of tonicity on the right side of the lip. So the surgeons, before the going for the additional biopsy or additional treatment, of course, you need to have a CT scan. So a CT scan was taken, and what we could see here was there is an obvious destruction of the mandible on the right side. There is loss of both the buccal and the lingual cortical plate, and rather than an expansion as such, it is fully destruction of both cortical plates extending till the posterior. And there was soft tissue density extending towards the adjacent musculature also. And also there were lymph nodes were also picked up. The level 1 and level 2, the level 1 and 2 on the right side were picked up in the CT scan. So seeing this or putting together this picture, the obvious, of course, amyloblastoma, yes, but amyloblastoma, typically you are more likely to see a multilocular radiolucency, what we usually see a soap bubble or maybe a small honeycomb, but this is rather more extensive. So even if it is an amyloblastoma, could it be an amyloblastic carcinoma? Then again, you have it's a posterior mandible, so you can think of other tumors which can arise, other lesions. That is, you have other naturally here because of the clinical and the radiographic presentation. Benign tumors were not even thought of. Other than amyloblastoma, most of the thought process went into a malignant tumors rather than benign tumor. And the other obvious things in that particular location arising from the mandible, of course, intraosseous primary. The oral mucosa was normal looking. So you can have a primary intraosseous carcinoma there, the odontogenic one, which can arise there. Then other probable ones are you have salivary gland tumors arising in the mandible. The location for salivary gland, the intraosseous salivary gland tumors are usually posterior mandible. Then again, because of the presence of that paresthesia, you have something called a numb chin syndrome. So you have to think of metastatic lesions. So these are the probable clinical differential diagnosis, what we have to think of at this particular stage. Now, because it appeared to be not as obvious amyloblastoma, the surgeons did a repeat biopsy for this particular case, and we got a slide where we could see mostly connective tissue stroma here, where there were lots of islands, nests, cords, and smaller area, all many, the tumor cells were seen in many presentation, in varied presentation with adjacent areas of hemorrhage. Here is this a cystic area or is it a degeneration again? Large islands, smaller nests, a varied picture was seen. Some areas, if you look at the tumor cells, some areas appeared more bluish or hyperchromatic, whereas the other areas appeared to be less darker in color or lighter in color compared to the other areas. So going to a little more higher view. So these were solid islands, large islands, where we could see these large ovoid looking cells with large nucleus. The nucleus appear to be pale staining with irregular chromatin. The cytoplasm appeared to be pale and not well. The nuclear margin, the cellular margins were not that clear, and it was very much cellular. And towards the periphery of these islands here, and this particular island, you can see there were some darker stained areas also, or darker stained cells here, which appear to be more basophilic, and the cytoplasm was not evident here. So these, as you can see here, see there is one tubular picture here, the solidness, some amount of degeneration, or some material seems to be here, some vessels, we don't know whether it is vessels, some hemorrhagic areas, then some tubular areas, some solidness. Then another area, we could see a focal cribriform kind of pattern. This is one area, or this is the only area where we could see a focal cribriform pattern. Now, if you see, this is a high power view of one of that solid islands, where you can see the center. This appears to be a area of degeneration or necrosis, which is known as comedonecrosis. When you see fast-growing tumors, fast-growing islands of tumors, where the central area undergoes degeneration, you call it as a comedonecrosis. And here, again, you can appreciate the two sets of cells, or a biphasic population of cells, which are separated by, say, are thrown into islands and large nest and the adjacent connective tissue stroma. Now, this is an area, again, here also you can appreciate smaller islands of these tumor cells. The two sets of cells are also very clear here. And you can see an area where the vessel invasion is there. See, you can see the blood vessel, the RBCs here. And though it's not clear here, there were endothelial cells surrounding this. So this was a vessel where you could see those darker stained cells infiltrating or invading into a, so there was a definite vascular invasion. And this was the tumor cells infiltrating into the adjacent adipose tissue. So into the adjacent soft tissue, where we could see in the CT scan where it was evident. So again, here also we are able to appreciate the two types of cells here, the darker stained cells and the lighter stained cells. And here there are some very unusual features in this tumor. This is a pattern which is called as micropapillary pattern. And this is one area in the tumor where we could see the tumor cells protruding into a kind of cavity in a micropapillary pattern. Then in another area, clear cells were also visible, but this is seen in only in a particular section alone. So clear cell areas, and you can see the other cells also in this particular slide. Then a tube area. Then periphery of the tumor showed extensive areas of desmoplasia, stromal hyalinization. And here the cells were mostly the dark blues, the spindly cells, or the darker staining cells, which were more ovoid to spindly in shape, and they were seen as slender cords also extending into the adjacent. So the margins were all, the tumor cells were seen just extending into the adjacent tissue. So a diagnosis, it's obviously a malignancy. We can make out it's a carcinoma. So it's a poorly differentiated carcinoma. What is its origin, or what is it? So first and foremost, seeing the histology, the tubular arrangement, the focal cribriform pattern, salivary gland malignancy, especially adenoid cystic carcinoma is the one which came foremost. Then again, you have to rule out other, but again, it is not a typical picture of any adenoid cystic carcinoma. So you have to think of other carcinomas also. You have the polymorphous adenocarcinoma, then you have not only salivary gland, then you have whether it's a basaloid squamous cell intraosseous carcinoma, then is it a odontogenic, that is the primary intraosseous carcinoma, then is it a metastatic lesion, metastatic carcinoma from a breast, maybe it can, may show a tubular pattern or a glandular pattern, can be seen in metastatic lesions, and is a female patient. So you have to rule out malignancies which arise, especially with the keeping in mind that the patient had a Namchin syndrome also. You have to definitely rule out metastatic lesions. So this was a case which definitely had a need for immunohistochemical analysis. So the first of one of the markers which we did was CK7. Sorry, this is a picture of CK7. So when we think of where the immunohistochemical markers, where you have an unknown primary, if at all you have to do, especially metastatic lesions, the markers, two markers which are first used are the CK7 and 20. CK7 is usually positive for tumors arising above the diaphragm, and CK20 for below the diaphragm. Here CK7 was positive and CK20 was actually negative. I have not put the slide here, but CK7 was alone positive. Then, so it is the epithelial tumor arising above the diaphragm. Next, the S100 was another marker which is used, which is focally positive in some of the areas. Then this is P63 was used, and P63 is positive in salivary gland tumors and also in odontogenic tumors, but P63 was negative here. So we had an initial panel here where CK7 was positive. Other markers were also done. CK20, as I said, was negative. S100 was present focally. P63 was negative. Then the other markers which were done was estrogen receptor for breast carcinomas, TTF1, which will be thrown positive in either thyroid and lung carcinomas, which is again negative, and synaptophysin to rule out other neuroendocrine tumors. These three were also negative. So we were still stuck into a tumor, or we were still with a tumor which is CK7 positive, but showed only S100 focally positive, but it was unfortunately P63 negative. So along with the immunohistochemical marking, the patient was also sent for a PET scanning to rule out the absence or the presence of other lesions elsewhere in the body. Now, PET scan showed lesion, the obvious lesion in the mandible. Along with that, there were lesions in the temporal bone. This is the picture on the right side top corner. B is where the intense uptake of the scan was seen in the mandible right side. Then she also had positive uptakes in the ischium and also in one of the vertebrae. So there were positive uptake in the mandible, in the vertebrae, in the ischium, and also in the skull bone. But the maximum uptake was found in the mandible itself. So this told us that the primary lesion was the mandible itself. So this also helped to rule out that it is not a metastatic lesion, but a tumor which has arisen within the mandible itself. So we are back at our differential diagnosis. So within the jawbone tumor which is arising, it has to be either odontogenic in origin or a salivary gland in origin. Within the jawbone, you can get salivary gland tumors also. So, see
10 o'clock, then that is 1 o'clock onwards, I'm awake.
Seeing the presence of, so thinking back, looking at the histology picture again, see, we saw a cribriform pattern. We saw a tubular pattern. Then there were areas, even though P63 was negative, S100 was positive. And also the primary lesion is in the mandible. So we came back at a possibility of a salivary gland tumor, and that too of an adenoid cystic carcinoma, maybe the solid variant or the high-grade variant, which will present as such solid tumor. So another definitive marker is there for adenoid cystic carcinoma, which is the CD117 or the c-KIT, which can help to differentiate between polymorphous adenocarcinoma also. And this CD117 was seen to be diffusely positive, and we could finally arrive at a diagnosis of primary intraosseous adenoid cystic carcinoma with distant skeletal metastasis. So patient had multiple skeletal metastasis. So you have the, in adenoid cystic carcinoma, you have the three variants. You have a tubular type, you can have the typical Swiss cheese or the cribriform pattern and the solid variant. The cribriform pattern is the one which we are usually familiar with the textbook pictures, and the Swiss cheese pattern, which we usually, it is imprinted into our brain. So, but we can get these cases of solid areas of variant of adenoid cystic carcinoma. So, if you look back, the one thing which helped us in diagnosis was the looking at the HND picture itself, the cribriform picture there, even though it is present in just one single area. So maybe that cribriform picture was indeed helpful in the final diagnosis. So, a take-home message from this particular case would be: look out for the positive things, or look out for the usual things in an unusual tumor, which could help us in diagnosis. So here, the focal area of cribriform pattern helped us in arriving at a diagnosis, where even immunohistochemistry was little confusing. Now, here another confusing picture was the absence of P63 staining. Now, P63 is usually taken up by the abluminal cells in the adenoid cystic carcinoma, but there is something called a high-grade transformation or a D-differentiation, which is earlier termed as D-differentiation salivary gland tumors. So when D-differentiation occurs or a high-grade transformation occurs in adenoid cystic carcinoma, it is characterized by the absence of, or the absence of the abluminal layer, as it has to be positively ascertained by an absence of IHC staining. And so this could be and have been an area of high-grade transformation in a solid adenoid cystic carcinoma. Now, for the follow-up of the case, this patient they went to another center because of other reasons. They went to other centers for treatment and was lost to follow-up. But the histologically looking, the clinically looking, the extensive metastasis and the histologic picture tends to give a poor prognosis to this particular case. So that is a wide variety of salivary gland cases which I presented to you. This sole picture, it is not salivary gland. That's the only clue I'll give you. This is a spot diagnosis. There is a small boy, about 4 to 5 years, who presented with bilateral swelling in the cheeks. Anybody with a spot answer? Anybody can give? Yes, somebody has already written here cherubism. So I'll just say it's a very classical picture of cherubism. I'll just show you the other pictures from this case. So this is the intraoral picture. You can see the swelling on the bilateral swelling of the mandible. But here, one unusual thing was the patient had lesion both in the maxilla and the mandible, and there were multiple lesions. So if you look up cherubism, you'll find that there is different subtypes depending upon the level of involvement in the bone, whether it is involving in the mandible alone or in the maxilla, whether it is involving multiple areas. There are different types or subtypes of cherubism which you can divide. So this is the classical floating tooth appearance, the classical histopath, the radiographic picture. Histopath was taken and giant cells, typical giant cells were seen. So of course, since the clinical picture, there is not a real need for a histopath picture for a diagnosis in this particular case, but the clinical and radiograph picture itself is sufficient. But there are other associated syndromes you have to rule out when you come across cherubism. Of course, in children, there are some syndromes where there is mental retardation. So you have to look up and to just rule out those syndromes when giving out a report of cherubism. And of course, there are wide other variety of differential diagnosis for giant lesions, which I'm not going into this at this particular point in time, because here the clinical and the radiograph itself is very much sufficient for the diagnosis. Thank you for a patient hearing. I hope the different cases which we have presented to you, very useful to you, and which might have helped you in gaining a better knowledge. And these cases are definitely helped us also in under many of the, as we see cases, as we go through literature, when we get these cases, it gives makes us more and more understanding of the wide variety of uh, differences or wide variety of changes or varieties which we can find in each and every tumor. But there are certain pointers in each and every case which can help us in diagnosing. So look out for these diagnosing, for those features which will help you in diagnosing. Thank you. And I would like to thank the organizers for giving us an opportunity. And especially me, I have my many teachers in this platform. One of my teachers is one of the moderators for this session, and I hope I have done, I have been justified ma'am's teaching. Thank you for your patient hearing.
Thank you.